My name is Peter Schupbach. I did my studies in Zurich at the Federal Technical High School. I went from there to several different jobs in the world and came back as a young doctor to the Dental Institute of the University of Zurich, where I spent 20 years leading histology, doing histology for a lot of groups there. And then I did the PD, I mean what we have in Switzerland and Germany, the allowance to lecture at the university. So I lectured about pathophysiology, of oral pathophysiology and all these things until to the year 2000. And then I stopped all this because there was no longer a challenge for me to be at the university. With other words, there was no seat free as a professor. So I left the university, built up my own lab, and from that time point on my life started to be really great, because it was so difficult at the beginning, but then it grew quite nice, and today we have a lab which is fully booked out with histology for several companies and groups, universities and doctors. So next to doing my life as histologist, I really enjoy life because it's much better than at the university. That means to me that we have, that the evolution brought us a very nice anchorage of our teeth in the alveolar bone, so it's sophisticated suspension by the periodontal ligament. Whereas osseointegration is the rather rigid ankylotic-like connection between a piece of metal with bone. So osseointegration for me, as P.I. Brannemarks learned us, is that such a rigid ankylotic connection absolutely works. So osseointegration works, that's for sure. No, that's absolutely a long-term phenomena. If everything is correct, I mean, if you, without any inflammatory reaction, or other problems with the, I mean, patient-related problems, then it should work for a lifetime. In my opinion, they are really absolutely similar, and we have to be aware that these rough surfaces, when you install them in bone, they will create something like a smear layer. So that means the surfaces act like a micro-grinded sandpaper, and this sandpaper, the sandpaper immobilizes bone. With other words, when you install an implant, then you create a smear layer on the surface layer. And the smear layer, of course, has all the growth factors in it. And the smear layer is created with all the rough surfaces of today. So probably, if there are differences, there are very small differences. So, but we have to think about what happens then without the smear layer. Sometimes you have only the tip of the threads in contact with bone and create a smear layer there, whereas in the remaining area you have no smear layer. And then the properties of a surface can show their full strength, how fast they support the bone formation. This for sure, if you place an implant or install an implant, then you have to do it without any irrigation, because we need the blood in direct, and we need the blood undiluted in a direct contact with the implant surface. So, and do not get me wrong, during drilling, of course, you have to cool. It's just during placement where you have to avoid any irrigation. Now, if you place an implant in very dense bone, and as you know, I'm a biologist, not a dentist, then sometimes you have difficulties to install the implant because the bone is so dense. So in my opinion, is just turn it in, then a little bit out, again in. I mean, you are a dentist, is this correct? Is this the correct view? So that by that you can overcome that, because I often hear the comment, hey Peter, what I'm doing if it's difficult to install the implant, should I then use irrigation, or what is there any damage? So of course there is no damage, but it's better to have the blood undiluted on the implant surface. No, no way. I mean, of course the Straumann Nobel Active is a very nice surface because it's completely clean, so that is an advantage. But to wet an implant surface before installation makes no sense now. Yeah, I mean, we have to be aware that the connective tissue, if everything is correct, is not to the implant but to the abutment. So, I mean, if you have a normal short junctional epithelium, if you do not change the abutment all the time, then you have the connective tissue around the abutment. And what we saw in our recent research is that you have in the connective tissue not only collagen fibers in an orientation parallel to the implant. I mean, if you have a long epithelium, of course, then you have to connect. You may have the connective tissue also to the implant collar. Then you have what is in the textbook everywhere, that you have an orientation of the cells and the collagen fibers parallel to the abutment walls or parallel to the implant collar. Of course you have that, but in addition, and much more important, you have circumferentially dense fiber bundles, and in absence of functionally oriented fibers, this O-ring of collagen fibers is absolutely important for the stability in the connective tissue to withstand forces during mastication and all these things. A direct attachment of collagen fibers to an abutment or to an implant surface is not possible today. Of course, you have the laser lock of BioHorizons, but also there you may have functionally oriented thin fibrils, but there is no evidence that these fibrils are anchored in the laser lock area. But what they have definitely is that for this O-ring about the abutments, and the BioHorizons laser lock area is on the apical area of the abutment, that in these microchannels the O-ring is fixed, so the fibers run in these microchannels, and of course this results in an improved stability of the connective tissue. Yeah, but the conical, absolutely correct for the conical connection, because we did a study in Zurich testing all these conical junctions to look if they are tight or if they are not tight, and they are, I mean, they are absolutely tight. Since you have the conical connections, you can forget about microgaps. That's no longer a problem, definitely. The platform switching, if I repeat myself of the importance of this O-ring, if you have the platform switching, then that we saw repeatedly in two different that we saw repeatedly in studies now, that this O-ring is directly sits on this platform, so it's fixed there, and by that the platform definitely influences also the outcome of the soft tissue. In bone, as you know, sometimes platform switching works, and in other cases it doesn't work. Again, I'm the biologist, so yeah, difficult question. But there are even people who are saying that peri-implantitis doesn't exist at all. Probably it's not the same as parodontitis, but peri-implantitis in my eyes absolutely exists. And I mean, I did hundreds of histological sections through different kind of abutments and surfaces with different surface properties. So in my eyes, it's definitely a bacterial story, because what I see I receive a lot of failures in my lab, which I have to check, are there bacteria, or what could be the reason, or is something wrong with the surface, or it's a fabrication failure, and with almost all of them, I see bacteria along the interface, and not only on the abutment, but not only on the collar, but down to the several threads. So the bacteria are there, and the bacteria. I mean, if you know how bacteria attach to a surface, then of course it's clear that bacteria have a problem to attach to a smooth surface. They attach only by the presence of the salivary pellicle there. But if you have a rough enough to form niches for the bacteria, then you run in a problem. And if you have a rough color with a patient with some patient-related factors which are not correct, or with a bad oral hygiene, then you need a safety zone there. So if I would be a dentist and would have such a patient, then I would choose an implant with a safety zone. That's for sure. Yeah? But because then you need the safety zone. No, in my eyes, this is not correct, because all the available implants today have about the same roughness. So why should thionite be more dangerous, a bigger risk than other surfaces? What probably is a fact, and this is, of course, this is all brought up by my colleague Berglund, thionite is probably more difficult to clean. That's the only reason. But there is not a bigger risk for peri-implantitis, that's for sure. Depends if you speak about today or the future or the past. So the past was filled with a lot of skiing and a lot of sports. So tennis, for example, and running. So that's at the moment is a little bit blocked because of my knees and my age. So, but the future, I don't know. I will continue to work first, and then we will see.